Hello students, welcome back, and in this video lecture we'll talk about the features of neoplasia. So we have four features of neoplasia: anaplasia, rate of growth, local invasion, and metastasis. We are talking about a cancer right now, and what are the features of cancer that we'll talk about in this particular lecture. We know that there is metastasis in the cancer. That means cancer cells, if they invade to some other organ, that short we know is a cancer, right? Then we can tell that with this particular person is having cancer when the cancer cells from the origin, they are going to some other route or they are going to some other organ. So that is known as metastasis. Metastasis is a sure or a reliable sign of malignancy. If a person is having metastasis, if the cancer is metastasized to other organ, that means we can tell that this person, we are having a cancer or this is a cancer. So if in exam they ask a sure or a reliable sign of the malignancy or cancer, it is going to be metastasis. Metastasis is from one area, it is metastasized to some other area. So that means shortly we know that there is a malignancy. Apart from that, we have features like anaplasia, which is a hallmark of neoplasia. Anaplasia word, you can remember that it is a hallmark of neoplasia. So you can actually easily remember anaplasia is a hallmark of neoplasia. We have local invasion of the cancer cells, and also there is a rate of growth. Now, local invasion is the second most reliable sign of neoplasia. See, locally these cancer cells are invaded, but if they are going to some other organ, that means short they are cancer cells. Metastasis is from one area, they are going to some distant locations, they are going to other area. If this is a tumor cell, if it is going to some other organ, that means 100% short it is going to be a malignancy or cancer. Local invasion means it is invading into the local area only. That is local invasion. So 100% if it is going to far away place, that means it is going to be metastasis. It is 100% going to be a cancer. If there is a local invasion, that is the second most reliable sign of a cancer or a neoplasia. So let's talk about anaplasia. I told you it is a hallmark of the neoplasia. So remember plasia word, if you can see plasia, anaplasia and neoplasia. So the hallmark of the neoplasia is anaplasia. Anaplasia is defined as loss of differentiation. What is differentiation? See, when a child grows up, the characteristic features, look-wise, appearance-wise, we say that this particular boy is on his parents. Half of his face is on mother, half of his face is on father. So this is structurally, we can say that this guy, composition-wise, this person is similar to the parents. But when the child grows up, once he gets married, and the way he behaves to his wife, it is similar to the way his father behaves to his mother. So the functions are similar. There is a nature similarity that is seen once the child grows up, right? So that means functionally and structurally, the child is on his parents. And this is what we call differentiation. Differentiation is the structural and functional similarity of the tumor to the parent organ. For example, if I say there is a tumor in the liver, these are the liver normal cells. This is a tumor cell. This normal cell, how it functions, how it is structurally made of, the tumor cell is similar to that cell. Tumor cell will exactly not look like. Tumor cell will behave, not look like the liver cell. So there is loss of differentiation. We can say that differentiation is lost, and this is known as anaplasia. The tumor cell will not functionally or will not structurally look like the native cells or the parent cell. So this is loss of differentiation, and this is a characteristic hallmark of the neoplasia. So hallmark of neoplasia is anaplasia. So far we have studied all of these hallmarks, and let's recall. Hallmark of apoptosis is nuclear chromatin condensation. But if we say neuronal apoptosis of a nerve, then it is apoptosis inducing factor. Barrett's esophagus, it is the goblet cells, which is the hallmark of Barrett's esophagus. Acute inflammation, increase in the vascular permeability, which is a vascular event of the acute inflammation. Increase in vascular permeability is the hallmark of acute inflammation. And chronic inflammation is tissue destruction. The hallmark of chronic inflammation is tissue destruction, and that is why repair process starts. So it is tissue destruction, and then the hallmark of repair is a granulation tissue, red color tissue that is formed, and that tells you about the person is having a healthy healing. So looking at the granulation tissue at day 3, we have already discussed this in the inflammation. So let's talk about the topic back again. That is, we are talking about anaplasia. We have a term that is dysplasia. We have studied in the previous parts of the general pathology lectures, and that is dysplasia. What is the difference between dysplasia and anaplasia? Dysplasia is a precancerous condition, while on the other hand, anaplasia is a cancerous condition. As I told you, it is a feature of neoplasia. Neoplasia means cancer or tumor, and anaplasia is a hallmark feature of neoplasia. So we know that anaplasia is short going to have features of cancer, but dysplasia is precancerous condition. First, let's talk about the common features between dysplasia and anaplasia, and then we'll talk about the differences between them. So common features, the first one include there is loss of polarity. Normally what happens, this is the basement membrane. We have the cells that lines the basement membrane. They have got nucleus towards the basement membrane. This is how a normal cell looks like. But a cancerous cell, if this is a basement membrane and these are the cancerous cells, these cancerous cell will have loss of polarity. So this is reversal of the polarity opposite to the basement membrane. Then they can have any kind of polarity. So this is loss of polarity that is seen in the neoplasia, that is seen in the dysplasia as well as anaplasia. Both of these will have, first is loss of polarity. Then there is pleomorphism. That means if this is a normal cell, we have the cuboidal epithelium, suppose. Then in case of dysplasia and anaplasia, there is going to be pleomorphism. They are going to have a variation in the shapes. So a pleomorphism, variation in the shapes and the sizes of the cell is also seen. So second feature, common feature is pleomorphism. Third feature is the nuclear to cytoplasmic ratio. Now, normally what happens if this is a normal cell, nuclear to cytoplasmic ratio is nuclear is at the numerator, cytoplasm is at the denominator. You can see nucleus is small, cytoplasm is very big. So it is either 1:4 or it is 1:6 in a normal cell. But in case of dysplastic or anaplastic cell or a cancerous cell, there is increased in the nuclear to cytoplasmic ratio. And you can see the nucleus is as big as almost the cell. So it is 1:1. Nuclear to cytoplasmic ratio is almost 1:1. Nuclear is equal, same size as that of the cytoplasm. Apart from this bigger size of the nucleus, there is darker nucleus that is seen, that is more blue color nucleus is seen. You can see a faded color of the normal cell and a darker nucleus of a cancerous cell. So cancerous cell is going to have more blue color, a darker nucleus. That is because of the high chromatin. We know that there is a lot of division going on, a lot of things going on in the cancerous cell, a lot of proliferation. Rate of growth is more. And that is why there is hyperchromasia. That is, there is more blue color cells. The nucleus is going to be more blue. That is because of the high chromatin. So hyperchromasia is seen in the anaplasia as well as dysplasia. Remember, it is a characteristic feature of the cancer. Mitosis. Mitosis signifies the division of the cells. So if you see these cancerous cells, it is going to show mitosis. So there is a sunburst appearance. It is showing that the cell is dividing. That is sunburst appearance or sunburst mitosis. Here also you can see the nucleus is dividing and you can see the Mercedes-Benz sign, right? So that again signifies the mitosis. So we have studied the common features between dysplasia and anaplasia. Now let's talk about the differences between dysplasia and anaplasia. If this is a basement membrane, as I told you, dysplasia is a precancerous condition, while on the other hand, anaplasia is the hallmark of neoplasia. That means anaplasia is going to be cancerous. If this is the basement membrane, we have the cells. These are the cancerous cells. Let's write TT. These are the cells. So basically, as long as the basement membrane is intact, we say it is dysplasia. So dysplasia is when the basement membrane is intact. Anaplasia is when the basement membrane is breached. There is discontinuity in the basement membrane and you can see the cells are leaking out and they metastasize to other organs. So this is breach in the basement membrane we can see in anaplasia, and that is why we call it a cancerous condition, because cells are going to the distant location. So anaplastic feature, this is anaplasia. The basement membrane is breached. It is a cancerous condition. Dysplasia, when the basement membrane is intact and it is a precancerous stage. We have also studied earlier about metaplasia. So metaplasia is when the tissue, one kind of tissue is changing to another kind of tissue. That is known as metaplasia. Dysplasia, we have studied, it is a precancerous condition, and anaplasia is the loss of differentiation. That is a cancerous condition, loss of differentiation, and that is a cancerous condition. Now, in metaplasia, one kind of tissue is changing to another kind of tissue, and this is a reversible process. The tissue can come back to its original form also. Dysplasia, on the other hand, is a partially reversible. While on the other hand, anaplasia is a cancer. Once a person has cancer, the tumor cells are not going to become normal. So it is an irreversible process. If you see dysplasia, we have studied this, that dysplasia is a precancerous condition. It is before the cancer. Now the basement membrane is intact in dysplasia, right? If we see the dysplasia of the cervix, that is cervical intraepithelial neoplasia. See, this is a neoplasia. Intraepithelial means this is a neoplasia that is within the epithelium. Intraepithelial. Cervical means because we are talking about the cervix. It is a dysplasia of the cervix, that is cervical intraepithelial neoplasia, which is known as CIN. Dysplasia of cervix is known as cervical intraepithelial neoplasia. It is not crossing the basement membrane. Basement membrane is intact. It is intraepithelial. We have different stages. The grade 1, when the dysplastic features are present in the lower 1/3 of the epithelium. When lower 2/3 of the epithelium shows the dysplasia, then it is known as type 2, CIN, cervical intraepithelial neoplasia, grade 2. Grade 3 is almost the, you can see almost the full thickness, not whole of the thickness, almost the full thickness is showing the dysplastic features. If the full thickness is covered, then it is known as carcinoma in situ. Here you can see the basement membrane is breached, the cancer cells are going somewhere, and this is a characteristic feature of anaplasia. When the basement membrane is breached and the cells are going, basement membrane is broken here, and this is anaplasia or the cancer. We have studied anaplasia. Let's talk about the second feature, that is rate of growth. So rate of growth for the benign tumor is actually less as compared to malignant tumor, which has more rate of growth. Now, when do we say, when a surgeon or a pathologist can actually tell that the person is having cancer? So clinically detectable cancer is when the weight of the tumor, weight of the cancer is 1 gram. That means the cancerous cells are going to be 10 raised to power 9. This much amount of cells will weigh 1 gram. And if the weight becomes 1 gram, then we can clinically detect that tumor. This is the minimum value. If the minimum value of the tumor in the weight is 1 gram, then we can detect the tumor. What is the maximum value? Maximum value is very easy, 1 kg. The maximum weight of the tumor that is compatible with the cell or that is compatible with the life, that is 1 kg of weight, and this consists of 10 raised to power 12 cancerous cells. And after this, the person cannot survive. So this is the maximum limit of the cells. That is 10 raised to power 12 cells that weighs 1 kg. If the tumor becomes more than 1 kg, it is very difficult for the person to survive. Now coming to the third factor, that is local invasion, and the fourth one, that is metastasis. We'll talk about both of these simultaneously. So local invasion means there is going to be local spread. If there is a cancer of the liver, this is the cancerous cells, it is going to go locally. That is a local invasion. Metastasis is, if this is a, not, let's take about the breast. If this is a breast cancer, when it invades to the other tissues, for example, it is going to the lung, it is going to the ovary or anywhere, then we can say that there is metastasis of the cancer. That means it is going to far away place. That is metastasis. Local invasion means, see, local invasion means you are traveling in the local area. You don't have time to explore other places. And metastasis is, say, after the wedding, going to honeymoon, going to the foreign countries, distance, far away place. Distant spread, that is known as metastasis. Going to the foreign trips, that is metastasis. Now, all the cancers are going to show metastasis except the cancers that are busy, because they are very busy. So remember the letter B, there are going to be two cancers. One is BCC, basal cell carcinoma, and basal cell carcinoma is also known as rodent ulcer. Why? Because actually it is going to penetrate whole of the cheek and it eats whole of the cheek. So that is why rodent, like a mouse, it eats up like this. So it eats up. So like a mouse, this is known as BCC, rodent ulcer, because it eats up whole of the area. Another B is brain tumor, that is known as glioma. Since they are very busy, B for busy, B for BCC, B for brain. So that is why these cancer will not show metastasis, except that all the other cancers shows the metastasis. So basal cell carcinoma and glioma are the one that stick to the particular area where it grows, where it happens. Now coming to the spread, that is metastasis. We know that metastasis is the distant spread. That means it is going to the foreign country for a trip. Either the route it can take is lymphatic route, blood route, or the cavities of the body. And it is, see, direct seeding of the body cavities means they are going to sit in the body cavity. These tumor will grow anywhere else, but they will come and sit in the body cavities. Transcelomic cavities are the spread is the one in which they are going to take the body cavity as a route. The road is going to be transcelomic cavity. That means the route is going to be body cavity. Coelom means body cavity. Trans means the transport medium here is, or the route here is the body cavity. That is why transcelomic. So they are taking the route, the road trip. So this is like lymphatic spread is like taking a cruise. Hematogenous spread taking a flight. Direct seeding of the body cavities is like taking a cab, or transcelomic cavity is taking a car and going on a road trip. So the road is the coelomic cavity, but they're going somewhere else. So they are going and sitting somewhere else, but the route they are taking is the body cavity. So these are the four spreads. Let's talk about these spread of metastasis one by one. The first one is the lymphatic spread. All the carcinomas takes the lymphatic channels, lymphatic route. So lymphatic spread is for all the carcinomas. Hematogenous spread is for all the sarcomas. All the sarcoma take the hematogenous route, the blood route. We have exception in both of these. All the carcinomas take the lymphatic route. We have three exceptions. One is RCC, renal cell carcinoma. Second is HCC, hepatocellular carcinoma. And the third one is FCT, follicular carcinoma of the thyroid. All these three are the carcinomas that take the hematogenous route. All the sarcomas take the hematogenous spread, that is the blood, via the blood. But we have an exception. We have two exceptions. The first one is rhabdomyosarcoma, which is a muscle sarcoma, and second one is synovial sarcoma. All the sarcoma, both of these are sarcoma. All the sarcomas take the hematogenous spread, but these two, that is rhabdomyosarcoma and synovial sarcoma, takes the lymphatic spread. So this is vice versa. All the carcinomas take the hematogenous route with three exceptions: renal cell carcinoma, hepatocellular carcinoma, and follicular carcinoma of thyroid. All the sarcomas take the hematogenous spread, but we have two exceptions, that is rhabdomyosarcoma and synovial sarcoma, that takes the lymphatic spread. So the hematogenous spread is via arteries and veins. Arteries have got thicker walls. And therefore it is very difficult to take this route, go through this route. While on the other hand, veins have got thin walls, and that is why it is easier for them to take this route. So veins are the one that are easily affected, right? Lymphatic spread, we have something known as sentinel lymph nodes. Sentinel lymph node are the one that are the first one to what is the word of meaning? What is the meaning of sentinel word? That is first. So first lymph node to receive the lymphatic drainage of organ, that is a sentinel lymph node. For example, if these are the breast, the sentinel lymph node for breast is axillary lymph node. These are the axillary lymph node in the axilla. Axillary lymph node are the sentinel lymph node or breast. That means breast are going to first give lymphatic drainage to the axilla. So the first lymph node that is to receive the lymphatic drainage from an organ, that is a sentinel lymph node. So that means if a cancer is going to be in the breast, that means the first thing it is going to go is in the axilla, because this is the first area, first lymph node that gets the lymphatic drainage here. So the breast cancer is going to be in the axillary lymph node, because it is going to metastasize to axilla, because this is the first lymph node. If this lymph node is not metastasis, if it is not involving the axilla, that means the cancer has not metastasized. But we have an exception here that is known as skip metastasis. That means what happens actually, this is mostly seen after a radiotherapy. So what happens, suppose before removing the cancer, a person has undergone the radiotherapy. In that case, there can be radiotherapy induced fibrosis in the axillary lymph node. In this case, the breast cancer will not metastasize to axillary lymph node because there is fibrosis in axillary lymph node. In fact, instead of going into the axillary lymph node, it goes to some other lymph node. That means it is skipping the metastasis. Metastasis is skipped here, and that is known as skip metastasis. Here, the cancer reroutes to other lymph node. Rather than taking the sentinel lymph node, it is taking some other lymph node. Sentinel lymph node are the first lymph node to receive the lymphatic drainage from an organ. So in breast cancer, it is going to be axillary lymph node. So breast cancer, it is going to first go to the axillary lymph node. But if it is not going to the axillary lymph node, suppose if after a radiotherapy there is fibrosis in this axillary lymph node, in that case it skips the axillary lymph node and goes to other lymph node. That is known as skip metastasis. And sentinel lymph node also, we have studied the concept of sentinel lymph node. So is the first lymph node to receive the lymphatic drainage of an organ. Now coming to the third type of metastasis, that is direct seeding of the body cavities. That means the cancer is going and sitting in the body cavities. That is direct seeding of the body cavities. Body cavities can be pleural cavity, can be pericardial cavity, can be peritoneal cavity. Peritoneal cavity is the one that is around all the GI organs, and that is why peritoneal cavity is the largest cavity in the body. Suppose if a person is having a mucinous tumor, if there is a mucin secreting CA appendix, carcinoma of appendix, and if a female is having ovarian mucinous tumor, both of these are mucinous cancer only. Mucinous cancer. So these cancer cells will spread to the peritoneal cavity. They will go and sit in the peritoneal cavity, and this is known as pseudomyxoma peritonei. So peritonei is because the peritoneal cavity is affected, the cancer is metastasizing to the peritoneal cavity. Pseudomyxoma is the mucinous parts are affected. It is a mucinous tumor, right? So that is why pseudomyxoma. The most common cause of pseudomyxoma peritonei is the appendix carcinoma. So the mucin, this one, the mucin secreting carcinoma of the appendix, this is the most common cause of the pseudomyxoma peritonei. Or we are talking about the cancers that are sitting into the peritoneal cavity. Another example can be distal end of the peritoneal. In the distal end of the peritoneal cavity, we have pouch of Douglas. If there is a cancer that is metastasizing from the gastric, that is gastric carcinoma. If gastric carcinoma is metastasizing and depositing into the peritoneal cavity, we have an area that is known as pouch of Douglas. And if this gastric carcinoma is coming and sitting in the pouch of Douglas, then it is known as Blummer shelf. So this is again another example for the direct seeding into the body cavity, direct seeding of the body cavities. We have another example. For example, a tumor in the brain that is known as medulloblastoma. Medulloblastoma is a tumor of the brain that is a cerebellum tumor. This tumor actually drops into the spinal cord and there is a drop metastasis. So this is third example for the direct seeding of the body cavities. So we have studied 3 examples in the direct seeding of the body cavities. The first one is pseudomyxoma peritonei, and most commonly it is caused by mucinous secreting carcinoma of the appendix. The second example is Blummer shelf, which is a gastric carcinoma metastasizing into the pouch of Douglas. This is an area in the peritoneal cavity again. And the third one is medulloblastoma, which is a cerebellum tumor that drops down into the spinal cord, and that is a drop metastasis. Now coming to the transcoelomic spread. Transcoelomic spread means, coelomic means body cavity. So here the root is going to be body cavity. Suppose if there is a carcinoma of the breast, if there is a another person having carcinoma in the stomach, if there is another person having carcinoma in the colon, or if another person having carcinoma in the pancreas. If there are 4 people having carcinoma at different locations. So suppose if this stomach cancer patient, if the cancer goes via the body cavity and it's get deposited in the ovary. See, the cancer is metastasizing to ovary, very far off organ from the stomach, but it is taking the route that is the body cavity. So that is known as transcoelomic spread. It goes via the body cavity to the ovary, and then it is deposited in the ovary, and this kind of tumor is known as Krukenberg tumor. Krukenberg tumor. This is a tumor from the stomach. It goes via the body cavity and then it gets deposited in the ovary. It is a tumor of the ovary that is known as Krukenberg tumor. So we have studied the 4 pathways of metastasis: lymphatic route, hematogenous route, direct seeding of the body cavities, and transcoelomic spread. Lymphatic spread is when it is taking the lymphatic channel. All the carcinomas take this route with exception of 3 carcinoma, that is renal cell carcinoma, hepatocellular carcinoma, and follicular carcinoma of thyroid. They take the hematogenous spread. Hematogenous spread is via all the sarcomas with 2 exceptions, that is rhabdomyosarcoma and synovial sarcoma. They take the lymphatic route. We have also studied direct seeding of the body cavities. That means the cancer is somewhere else and it is going and sitting into the body cavity. And we have studied 3 examples of the peritoneal, 2 examples of the peritoneal cavity. One is pseudomyxoma peritonei, in which there is a mucin secreted carcinoma of appendix most commonly, or there can be ovarian mucinous carcinoma that can cause the pseudomyxoma peritonei. So basically they are going and sitting into the peritoneum. Another example is Blummer shelf. Blummer shelf is the one in which there is metastasis deposit from the gastric carcinoma into the pouch of Douglas, that is an area present at the distal end of the peritoneal cavity. The third example is medulloblastoma, that is a tumor of cerebellum, and that goes and drops down into the spinal cord, and that is known as drop metastasis. Transcoelomic spread is when it is taking the route that is a body cavity but sitting somewhere else. So now talking about the tumors that shows bony metastasis. That means these are the tumor that are going to go and sit in the bone. That shows the tumor metastasis. So we have mnemonic for these tumors, which is public toilet. Just write instead of C, K. So public instead of C, write K, toilet. P for prostate cancer. This is a tumor of prostate. It goes into the area closer to the prostate, that is lumbosacral area. So it goes into the lumbosacral bone via a venous plexus in that particular area, that is known as Batson's venous plexus. So the first example is going to be prostate cancer that goes and sit into the lumbosacral bone. Second U is nothing is with the U. Third one is breast cancer. So it goes into the thoracic vertebrae or goes to the ribs, that particularly goes and sit into the bone. Then from I we have public L, P-U-B-L-L. Public. L is the lung cancer. I is the intestinal cancer. And K is the kidney cancer, or you can say renal cancer. Just write the kidney. And then from T we have toilet as the thyroid cancer. So these are the cancers that goes and sit into the bone. For example, thyroid cancer goes and sit in the cervical vertebrae. So basically, these are the cancers that go and sit into the bone. Public, toilet. P for prostate cancer, B for breast cancer, U there is nothing with U. L is the lung cancer, I is the intestinal cancer, K is the kidney, and T for thyroid. So prostate and breast cancer are the two cancers that can go and sit in the bone. Either they can make the bone or break the bone. So they can be, see, the prostate cancer is going to be osteoblastic. The prostate cancer is going to make the bone. When it goes and sit into the bone, it is going to have osteoblastic. While on the other hand, breast cancer and lung cancer, both of these, breast cancer and lung cancer, these cancer can either be osteoblastic or it can be osteoclastic. Either they can make the bone or break the bone. So they are going to be either osteoblastic or osteolytic. Breast cancer and lung cancer, both of these goes and sit into the bone. So they shows a bony metastasis. While on the other hand, intestinal cancer, kidney cancer, or thyroid cancer, intestinal, renal, or thyroid cancer, all three are osteolytic. So we have started with osteoblastic, that is prostate. It is going to make the bone. It will show the osteoblastic cell. Prostate cancer is osteoblastic. Then we have studied both two, osteoblastic and osteolytic, that is breast cancer and lung cancer. And then last three are osteolytic, lies the bone. So starting with blast, then two osteoblastic, osteoclastic, and then last three are osteolastic. Intestinal, renal, and thyroid, all three are osteolytic cancers. So these are the cancers that show bony metastasis. So we have finished with the features of neoplasia. In this chapter, we have studied about anaplasia, then the rate of growth. Then what is the third feature? That is going to be local invasion into the local tissues. And then there is metastasis, the invasion to the distant tissue. And then we have studied about the paths of metastasis, the route that the cancer is taking. So this finishes the features of neoplasia. All the best.